is Rishika Singh. I'm a fourth year here at UT, and today I'm going to be talking about a unique case of new HIV presenting as possible high-grade lymphoma. So this was a patient that I saw on my hemonc rotation. He was a 60-year-old Black male who came into the ER. He had no significant past medical history, but he did have a multitude of symptoms over the past month, including a significant 40-pound weight loss, abdominal pain, decreased appetite, and fatigue. And upon further questioning, we learned that he also had fevers, dyspnea on exertion, and some drenching night sweats. So to me as a med student, this raises two big things. One is cancer and one is some infectious cause like TB. And the team investigating also felt the same way. So we were brought on board as part of the hemonc team, mostly because he had all these B symptoms that, were concerning for a large lymphoma. So on physical exam, we saw that he did have this diffuse abdominal tenderness, but he also had several asymmetric, firm, mobile lymph nodes, and these were in the preauricular, cervical, and inguinal regions. He also got some imaging done while he was in the ER. So his CT showed he had multiple pulmonary lesions and also had bulky retroperitoneal lymphadenopathy, which can be seen in these images. His labs were also significant for pancytopenia, and he had an elevated LDH. So this kind of didn't clarify the differential at this point in time because he could either have lymphoma or he could have some infectious process. So we maintained this wide differential and continued our investigation. With the imaging that we saw, it could also be something like miliary TB. So it was a really interesting case to work up. After we conducted some more tests, we found a positive HIV test. And to me, I was like, okay, so that means it's infectious for sure. But my attending informed me that there is HIV-induced high-grade lymphoma. So I thought this was really interesting because I hadn't really learned about that at that point in time. So people with HIV infections are at increased risk for lymphoma, in particular non-Hodgkin's lymphoma and other more aggressive lymphomas such as diffuse large B-cell lymphoma, primary CNS lymphoma, or Burkitt's. And there are a variety of considerations of why this might be the case. One is due to immunosuppression with HIV and cytokine dysregulation, which can cause increased B-cell proliferation and lead to diffuse large B-cell lymphoma. Another consideration is the possibility of immunocompromised patients developing more oncogenic viruses like herpes and EBV. So research is still pending into the pathogenesis of if patients with HIV that develop lymphoma have a different pathogenesis to develop it rather than the patients without HIV. Additionally, patients with HIV tend to present with a more advanced stage of disease. They usually have B symptoms, extranodal involvement, and further metastases at time of presentation. Interestingly enough, there have also been studies done showing that patients with HIV, up to 10% of the deaths in AIDS patients can be attributed to cancer, and non-Hodgkin's lymphoma is the most common cancer in patients with HIV. So returning back to our case, since we found this positive HIV test, we also were concerned for more opportunistic infections such as MAC or PJP. So we conducted more further testing. Everybody was really under the impression that he was going to have some sort of cancer. So we did a bone marrow biopsy and a lymph node biopsy. And while we were waiting on these results, he actually spiked a fever. So we became even more concerned and started him on broad spectrum antibiotics and antifungals, including vancomycin, cefepime, Bactrim, and amphotericin. And we found while we were waiting on the results of the bone marrow and the lymph node biopsies that he also had a positive histoantigen. So the new running theory became that he had disseminated histoplasmosis in the setting of new HIV. The bone marrow biopsy actually further confirmed this because it showed normal cellular bone marrow, but did have the presence of yeast forms. And the lymph nodes also returned with multiple non-necrotizing granulomas with giant cell reactions and no actual evidence of neoplasm. So he was started on itraconazole, and after genotype analysis of his HIV, was also started on Biktarvy and Bactrim for prophylaxis. And last I saw, he was seen by Regional 1 Stealth Specialty Clinic. His CD4 count had gone up, his viral load had gone down. He had gained some weight and was back at work. So I thought this case was really interesting because despite the B symptoms and so many things pointing us towards lymphoma, we did not anchor on that. We, tried to avoid confirmation bias or anything and kept doing diverse testing. And the testing that we did to confirm the lymphoma actually confirmed the disseminated histoplasmosis. So with that, I will end my presentation and open up to any questions.
Did you do any brain imaging at any point?
We actually did not do any brain imaging. He didn't have any altered mental status or anything, but primary CNS lymphoma is something that's found in patients with HIV. So I think if there were more symptoms pointing towards that, that would have been warranted.
Any other question? Thank you.
Thank you.